Well, hello, I'm Dean Kereiakes. I'm chairman of the Christ Hospital Heart Vascular Institute and professor of medicine at the University of Cincinnati, clinical professor of medicine at The Ohio State University, and I'm also deputy editor of SCAI. It's really a privilege to represent the journal, SCAI, and the editor-in-chief, Alexandra Lansky. And today we're going to discuss an important paper published in SCAI that's entitled Angiography-Derived Physiology for Coronary Artery Disease Assessment, Expert Opinion from a SCAI, that's SCAI Roundtable. To hear today is the presenter and lead author, Evan Shlofmitz, who is Director of Intravascular Imaging at St. Francis Hospital, also co-director of the OPCI program. Our panelists include William Fearon, professor of medicine and chief of interventional cardiology at Stanford University, and Birgitte Anderson, research affiliate at the Department of Cardiology, Aarhus University in Denmark. Evan, please summarize the roundtable discussion and the take-home bullet points.
All right. Well, thanks so much. Thanks for having me. So I think just an important note, there was a funding source. So for the SCAI Roundtable, it was supported by an unrestricted grant from Catholics and Medtronic. However, neither company had any role in the drafting, review, or editing of this manuscript, nor the content of the roundtable. So as some background, we know that angio-derived physiology, or ADP, is an emerging technique to assess coronary physiology without the need for a pressure wire. And this offers a streamlined, wire-free, drug-free assessment of epicardial coronary physiology. Now, the ADP approach can have a potential paradigm shift in cath lab workflow, but I think even more importantly, this can help to overcome a lot of the utilization issues that have existed to date with coronary physiology and help with more universal incorporation of using coronary physiology routinely in the cath lab. Now, despite the early promise of angio-derived physiology, there are a number of obstacles to adoption and routine use, and this document represents expert opinion that occurred after a scientific roundtable on ADP that was sponsored by the Society for Cardiovascular Angiography and Interventions, so SCAI. So we know there are a number of advantages of angio-derived physiology. There's no need for anticoagulation, no need for guide catheters and wiring of vessel and pressure wires or inducing hyperemia. And as a result, it can shorten procedure time and overall procedural cost. And we're hoping that some of these advantages can help to increase the utilization of physiology in the cath lab. But we also know there are some barriers to helping enhance this utilization that exists. And that's one of the goals of this roundtable, was to help try to identify ways and tools to overcome these barriers and what was needed for the field. Now, the cutoff for angio-derived physiology, it's a universal cutoff of less than or equal to 0.80, so exactly the same as with fractional flow reserve. Now, there are a number of potential clinical applications of angiography-derived physiology. It's not just a green light, red light for when to do PCI, but I think really the contemporary physiology focus is on what to do with that information, how to use it. And that's really where you have that advantage with the functional disease pattern. Angio-derived physiology can help us determine, is it a diffuse or focal disease state? With serial lesions, which lesion is contributing most to the ischemia and which would most benefit from revascularization or combination of lesions. You can do virtual pressure pullback and assessment and planning, which helps us to test offline in real time what's the best stenting strategy, rather than implant the stent and then add another one and add another stent to be able to relieve adequate ischemia. We can test this in real time virtually to come up with the best PCI strategy for that patient. It also helps to facilitate post-PCI physiology assessment, which utilization right now in post-PCI physiology has been very low. And there's a number of clinical and anatomical scenarios where there are potential advantages of angiographic-derived physiology compared with wire-based physiology, and they include with acute coronary syndrome, multi-vessel disease, tortuous vessels, or patients who have significant valve disease. And this is just a representative example. This is an example of the Kereiakes system, where here with the FFR angio, we're seeing an example on the left, the pre-PCI, but you see not only does it show you that there's ischemia, but there's helpfulness with the pullback in determining where there's ischemia, which lesions are contributing to it. And with planning, we can predict what a post-PCI FFR angio is, and the same system is useful in the angio-derived physiology post-PCI, assessing did we achieve what we sought out to achieve. And using this is really the modern way to use physiology for not only when to revascularize and when revascularization is indicated, but for guidance with procedure optimization, both pre and post, on what's the best way to successfully revascularize a patient. Now, with the barriers, I think this is something that really I look forward to the discussion during this session on how to best overcome this. But evidence, there's clearly a need for additional data, and the largest of which is going to be presented in the next year. And we're joined by the PI, Dr. Fearon. So we'll hear more maybe about what's to come with the All-Rise clinical trial. Training, like anything, I think it's very important that cath lab staff, and particularly physicians, are aware of what's necessary to have accurate data. And it really comes down to the basics of high quality angiograms, help to get higher quality data input for angio-derived physiology. But it's important not just the physicians, but cath lab staff have adequate training in how to incorporate this. Part of helping with utilization is integration to the cath lab to help with the overall workflow. And then, of course, as additional data comes out with additional evidence, how this will impact guidelines both in the US and globally as well. So with that, hope you read the article. Our expert opinion from the SCAI Roundtable is published at JSCAI and available online. And I'd like to thank my co-chair of the session, Dr. Fearon, as well as co-first author, Dr. Dusop Shin, and all of our co-authors who participated from around the world. So thank you very much, and I look forward to the discussion.
Evan, that was really great. There is a ton of information in this paper. And briefly, there are three major systems that are described. If you could give us the relative merits, if you will, benefits, advantages, I would say merit versus limitation of the one flow-based compared to the other two resistance-based systems. Just as for people that are not in this space, tell us what would be the relative benefits of one versus the other. Bill and Birgitte, chime in.
I'll open it to the panel, but just as introduction. So in the U.S., there had been largely three commercially available systems, one from CathWorks, one from PI, and one from Metis. And just recently, a fourth system, SpectraWave, just had approval of their system. So there are a number of different systems, and there are differences in the different systems, and whether it's flow-based or resistance-based. But there's also individual differences between the systems in how many angiographic views are necessary to derive this data, and that can range anywhere from one, and so what's necessary in SpectraWave's X1 FFR system, to 3 views, which is what's necessary for CathWorks FFR angio-based system. There's nuances with the differences, and I think which one is better or what's better for different clinical scenarios, I think we have to proceed with some caution, just as a result of limited data and comparing the different systems. And I think that's really what I think would make for I look forward to hearing what the panelists have to say, because I think whether this should be evaluated as a class effect between all angio-derived physiology systems, or if we need data on the individual systems is something that I think is up for debate given the nuances between the different systems.
Yeah, I can add
Birgitte,
on to the
go ahead.
CathWorks, and then I know Birgitte has a lot of experience with QFR and can speak about that. As Evan mentioned with the CathWorks FFR angio system, you do need 3 orthogonal projections, which isn't really too burdensome because generally we're doing 3 angles, if not more, when we're taking our pictures. And you have to do good angiograms, make sure that you have the catheter engaged well, that you're filling the entire coronary tree, that you try not to pan the table too much, and that you have the zoom set up so that you can see the entire vessel. You do need to input the mean arterial pressure, again, not really too burdensome there, to help calculate the FFR angio. But one of the nice advantages of the system is that it doesn't just interrogate the vessel that you're interested in, but it does the entire coronary tree. So for the left coronary, it'll do the LAD and the circumflex and the branches. And occasionally, you'll be looking at a proximal LAD lesion and it'll pick up another lesion in the circumflex that you might not have even really appreciated. So, and I think with the 3-dimensional reconstruction that's created, it does give you a lot of additional information about relationship between side branches and, bifurcations, and if you're going to have to do a crossing over a bifurcation, things like that. So there's a lot of additional information beyond just the yes, no on the FFR angio. I'll stop there, and maybe Birgitte, you want to talk about the QFR?
Yeah, of course. And first, thank you for the opportunity to be here today and talk about angio-derived physiology. I think, first of all, to address this question about a class effect, I would say that we shouldn't expect that. I would not believe that modalities with so different user interfaces, different algorithms, etc., would be expected to have a class effect. And then coming back to the differences between the methods, QFR only needs 2 projections and does not need the information about the aortic pressure. And you can say that might make it more easy and faster. And of course, every time you make something more simple, like also only using 1 projection, you might lose some information. And that is always the balance between these things, making it simple and making it feasible and usable, and still putting in everything you need to have a good enough accuracy. So I think that the methods are very different, both in what we put in and how they process the information that we put in. And then also we need to have evidence for all of these methods. I don't think we can say that just because the FAVOR3 Europe trial did not meet non-inferiority, we should expect the same for the others. So as William Fearon said to me a few years ago, or 1.5 year ago, we shouldn't flush the baby out with the bathing water. So we should maybe wait for the next studies, and we are very excited to see both the all-rise and FAST-3 results.
I'd like to ask both of you something, because you both brought up things. In this paper, it says that the FFR angio by CathWorks is the only system that can provide multi-vessel FFR. Bill, you brought that up. It also talks about the simulated pullback for sequential stenosis, which I think is very valuable, and it's really the only system. For example, I'm not sure that QFR can do that, and Birgitte, I'd like you to address that. An advantage of QFR is that you can do it retrospectively, and you don't require the mean arterial pressure. So core lab adjudication, I think, is very easy, much easier here, I think, overall, potentially. But then it leads to an issue of where the core lab doesn't consistently coincide with the site measurement. So, Birgitte, that's going to be a second question for you because you know where I'm going with that. Bill, what about the sequential pullback and the ability to do multi-vessel? Do any of the other systems offer that?
Well, I don't have a lot of experience, so I'll defer to Birgitte on the QFR and what the latest is as far as the pullback there and VFFR. The CathWorks system does provide that. I think, one of the messages we wanted to get across from this paper too is really the differences between angio-derived physiology in general and pressure wire physiology. As you know, Dean, it's extremely painful to, sometimes to get a pressure wire down the vessel and then do a pullback and then have to recross and then do an intervention. And then if you want to do a post-PCI FFR and you didn't do your intervention over the wire, you have to put the wire back down through the stent, and all that can be very time consuming. And I think all of the systems really help streamline and allow you to avoid those steps. Just to give the listener an idea, when we're doing our angiograms, the images are automatically transferred to the CathWorks console. So while we're shooting the left coronary, they're being sent over there. Maybe we see a moderate LAD lesion or a serial lesion, like you said, Dean. Then while we're going to shoot the right coronary, your technician or a fellow or colleague, whoever can be doing the FFR angio on those serial lesions in the LAD while you're getting your right coronary images. So literally, when you're done with the right coronary, you have the answer. And the pullback and assessing serial lesions is, I think, really one of the huge advantages of angio-derived physiology, because you can do, as Evan alluded to in his brief talk, you can virtually stent one lesion and see what the FFR angio would be, and then you can stent two of them and see what it would be. And so it can really help you decide how to best manage these serial lesions without having to remeasure FFR and pull back your wire and put it back down. So that is one of the, I think, the nice advantages.
Yeah, that ability for that virtual planning, I think that's really how we advance as a field. That gone should be the days where you just test out, let's stent this and then see how that distal or proximal lesion looks. You can virtually do this, and that's the whole essence of patient-centered approach, that to be able to virtually do this real time helps us to achieve better results, so that you're implanting the right size stent, the right lane stent up front from the get-go. And maybe just to add also just the reduction in artifact. One of the issues with wire-based physiology as well, there's high rates of drift and artifact that are often unrecognized. And with angio-derived physiology, it helps to overcome a lot of those errors as well.
Birgitte, you could address maybe the repeat QFR sub-study of Favor 3 Europe and why that would happen when so much other data showed highly significant correlations.
Yeah, and that's of course a very important question. The repeat QFR study was a reevaluation and a new assessment of QFR in the QFR group in the Favor 3 Europe trial. So it's more than 1,100 vessels that have been reanalyzed. And I think what we need to take from this, which showed very modest reproducibility, is that when we use non-cherry-picked angiograms from a real-world setting, we may have more reproducibility issues than when we use these highly selected images that are often applied in the other trials or in the early trials. And I think this is just another study that confirms that we really need these randomized trials, and we need them for all these methods. And we need the large real-world data to look into the actual barriers and the actual downsides of these methods to be able to evaluate those. So the first or the early studies seem to be a bit polished when we have not used images of the same quality that we actually can obtain in real world practice. That is my best guess, as the repeat QFR study also showed that with decreasing image quality, the reproducibility was lower, the variability was higher. Yeah, and I think that is very important, this high or this major reproducibility issue for QFR, which may also be a problem for some of the other softwares, or at least we need to have good studies to know that it's not. And therefore, I think that although we have substantial potential in these pullback curves and in the PCI planning and all these amazing things that these technologies can potentially bring to the cath lab, I think we also need to remember that we are not there yet. We're still missing evidence. So this evidence gap, Evan, that you showed us as one of the first things that we need to look into now, I think that is the most important. We need to await this evidence, and maybe some improvements are needed in some of the algorithms or in some of the methods before they can be implemented in real world practice.
We looked at a paper about a year ago in SCAI that had a single view QFR. Can you talk about, I'm sure you know about that, the single view rather than two views that have to be 30 degrees apart or whatever. Is it possible to use a single view with QFR?
No, not with QFR, but the Murray law-based QFR that is from a Chinese company, they offer this single view. It's actually a further development of the QFR algorithm. And we have been looking a bit into that, and we actually presented some of the results at TCT, and we see that they perform approximately the same when compared to FFR. So there's not a big difference between their performance. We were hoping that because some of the reproducibility issues may be addressed with this more optimized software only requiring one angiographic image, we may also see some better accuracy. But it was very much alike. Yeah.
Yeah, that's the pulse medical system, but the newer SpectraWave's X1 FFR system also has that single view angio-derived physiology. Their study is ongoing and hasn't been presented yet as well. So the accuracy remains to be seen.
Could you guys touch on some of the limitations? I mean, things have been excluded from trials like aortoosteo, left main, myocardial bridge. I mean, is there still a segment of patients that we're going to get a wire one way or the other, or is the angiography-derived physiology ready for prime time in those more common but complex lesions?
I think these are all scenarios where there actually may be an advantage with angio-derived physiology compared with not only needing a guide wire anticoagulation, but oftentimes adenosine to achieve hyperemia. I think there's actually an advantage with angio-derived physiology, not only potentially for the accuracy, but for utilization. Very often in clinical practice, we see cases where no physiology is used because of those scenarios you mentioned. People want to avoid wiring the lesion. And as a result, we're just eyeballing and making a guesstimate truly based on visual stenosis, which we know is a very poor indicator of functional significance. So to me, I think one of the major advantages with angio-derived physiology is to increase the overall utilization of physiology. So we're making our decisions based on more objective data. In the U.S., one of the things that I think is really important, about 10% of diagnostic catheterizations are performed by a non-interventional cardiologist, and oftentimes, so these are cardiologists who cannot do wire-based physiology. And if a patient has an intermediate lesion, for them to get further assessment with invasive physiology would need oftentimes a staged procedure, a staged diagnostic procedure, where here we're putting the tools of physiologic and functional assessment in the hands of anyone performing a diagnostic cath will have the tools to be able to get objective data assessment.
Yeah, I think, Dean, beyond the aorto-osteal limitation, I mean, you need good angiograms. You need to be able to see the lesion, and there are cases where there's so much tortuosity or vessel overlap that you just can't see the lesion well and document it, and that can be a challenge. Patients who've had a prior bypass, we haven't been able to figure out yet if the graft is patent, how to deal with that. If they have, for example, a right coronary lesion and there's no graft to the right, you can still use the system in that setting. But there are also some advantages that Evan alluded to. For example, in the case of acute coronary syndrome, there's a lot of concern about non-culprit disease and whether there might be global microvascular dysfunction or there may be hemodynamic perturbations that affect either your FFR or your non-hyperemic pressure ratio. And in theory, the angio-derived physiology shouldn't be impacted by those and potentially could be more accurate. The other setting, the aortic stenosis, where there could be LVH and changes in the microvasculature, again, that say would resolve after you do a TAVR, for example. The angio-derived physiology should not be impacted by those either. So we need more data, of course, to evaluate these settings, but I think with everything, there's pros and cons.
What's the permeation of this technology in U.S. labs today? What would you say is they say wire-based technology in your paper, you say is used like 10 to 20%. Actually, in our lab, I would say more. But now, because of CathWorks, most people are at least doing that or enrolling in the trial. What is the utilization of angio-derived physiology across the U.S. right now?
I haven't seen any recent data, partially just because this is emerging technology. There's such a rise with this. I think that's been rapidly changing from quarter to quarter, but I haven't seen anything from the past year as far as what that utilization is. A big part is going to be the integration as the systems roll out to additional cath labs in the U.S. The ability for that uptake to exceed wire-based physiology, I think, is certainly there. And the goal would be that this doesn't take as long as it took to get wire-based physiology, or let's say intracoronary imaging to the levels that it is today. I don't know if any of the other panelists have seen any other data on the utilization, but it's just, I think, given their emerging nature, this is something that's rapidly changing. But as far as the integration, so these systems work vendor independent as far as what your radiation equipment is, but there's different ways to integrate these systems in the cath lab. And as integration improves with the different systems, I think that'll help with uptake as well.
Another thing, I've always admired the European guidelines because I always tell people they're always running about 3 years or more ahead of us in the U.S. And I'll take a little swipe there for drug-coated balloons in more than a decade. But the European guidelines, after reading your paper, I look back, and Birgitte, maybe you want to address this. For multivessel disease, they give QFR at 1B recommendation and don't mention angio-FFR, which, according to this paper, is the only technology can provide multivessel FFR. They also, for general use, single vessel, they give QFR 1B and angio-FFR at 2B, which is about the lowest thing you'd actually do for a patient. So I'm not sure that the European guidelines didn't jump the gun. Can you address that?
Yeah, I think that that QFR has a higher recommendation, as that at that point it was the only trial that actually, or the only software that actually had a randomized controlled trial that compared it to angiography-based or angiography-guided PCI, and therefore they based their guideline recommendation on the FAVOR3 China trial. that showed that it was superior to angio-guided PCI. And I think that when we talk about the multi-vessel analysis, QFR can also do multi-vessel, but it just needs an analysis for each of the study vessels. So for each intermediate lesion, you need to do an analysis. So like for angio or FFR angio, you need to do one for the left and one for the right. Then for QFR, you need to do one for each lesion side. So one for the circ, one for the LAD, one for the right coronary artery, one for the obtuse marginal if you want that as well. So yeah, but I think that some might believe, or at least we try to do science to inform the guidelines. So with the FAVOR-3 Europe trial, we of course wanted to inform the guidelines. The guidelines was changed 2 months before we published our trial. And of course, based on the results that we got, we think that the guidelines are now informed about something else that the decision that they took before the publication of our results. But I also know that it must be a very difficult job to be in those guidelines. So it's not my job to say if they should change it. I'm just looking into the evidence that we have.
And that's why they keep updating guidelines. That's always the natural, that's why we conduct studies, and results aren't always what it seems. And it's always an evolving field.
Sometimes the U.S. guidelines kind of like the Doubting Thomas, though. I mean, you've got to have so much weight of evidence that it takes years sometimes. The application of artificial intelligence, and your manuscript is described both for QFR and FFR angio. And it's very interesting, Birgitte. QFR utilizes artificial intelligence to streamline the process, but also to reduce user variability. And yet we see variability between the site determined and the core lab adjudicated, where about 30% of the study
but here we need to remember a few things, I think, because we investigate QFR version 2.0, and there has been major advances in the AI integration of the software in the later versions. So when you read these papers from the FAVOR-3 trial, it is the QFR version 2.0 that we are testing. And because that is what was used in the trial, we actually wanted to do some studies with newer versions, but we have not been allowed to do so yet, or at least we have not been provided with the software. We think that these newer versions are already improving in terms of user variability, but we have not yet seen any changes in accuracy. So we are still awaiting new trials addressing if these newer and maybe improved versions in terms of the ease of use and the user variability, if they also translate into results that are closer to the actual FFR value.
Right, because beyond just the accuracy, just the ease of use, there's been, with the different iterations incorporating AI more and more, it substantially helps with the overall ease of use as well as the speed of assessment, which are obviously factors that help to drive utilization.
Agreed. And it's very important because we are introducing these methods in the hope for increased utilization. That is our hope, a worldwide increased adoption of physiology-based assessment of these lesions. That is what we have been aiming for with these new technologies. And therefore it needs to be user-friendly, and it needs to be fast and also actually cheap.
Use of AI for facilitation of process, but also quality control. I think it's much like we try to do in MRI, et cetera, and other imaging. technologies. Are there any closing comments that any of you want to make? This has been a great, I think, initial discussion for many people who are going to watch it on angio-derived physiology. Any closing comments?
I think as people go through their own evolution of if this is something new for you, and as you're adopting angiographic-derived physiology in your own workflow in cath lab, one of the most interesting things during that evolution is it makes you a better angiographer because you start realizing the data necessary to have high quality assessments require you to go back to the basics of high quality angiograms with minimizing vessel overlap, making sure the entire coronary tree is within frame and minimizing panning. And that really helps with the foundation of higher quality angiograms and data input to begin with. And this way we can make our best decisions for our patients and increase the use of objective information. So I think this will help to impact the field and improve our overall work that we do in the cath lab.
Yeah, I wanted to emphasize something Birgitte said in that, one of the goals of this roundtable was to, educate people and update them on the data and where things stand with the angio-derived physiology, with the goal of just increasing the utilization of physiology in general. We have so much data supporting it to guide PCI, yet it's underutilized for a number of reasons. And hopefully these new systems, whichever ones, the data support using will help us increase our utilization. I would make a plug that Evan alluded to the All-Rise trial. This is a study of 2,000 patients randomized to either the FFR angio guided revascularization or pressure wire with either an FFR or non-hyperemic pressure ratio. We hope to be presenting it at ACC this spring as a late-breaking trial. So stay tuned for those results because clearly we need more data.
Looking forward.
Good. Excellent. Birgitte, anything you'll say in closing?
I'm just looking very much forward to the next studies and to the next developments in these different systems. And I hope that one day it will be good enough to be implemented in routine clinical practice, and we will have enough data to actually increase the utilization.
Completely agree with you on that. I want to thank you, Evan, for your presentation, Birgitte and Bill, for incredible, insightful comments. I think we've all here, hopefully this vehicle will increase the awareness, I think, of angiography-derived physiology, nationally, at least in the U.S. And I want to thank SCAI for giving us this opportunity. It's a great platform, I think, to bring to the forefront with a better discussion, and more people will actually go and read the paper now because of it. So I think this is a great opportunity that SCAI provides. So thank you, each of you, and really appreciate your participation.